Welcome to Lecture Boss. My name is Dr. David Averbach, and today we'll be discussing the best treatment options for the most common cardiovascular conditions that appear on steps 1, 2, and 3, and the shelf exams. This will be the first of two lectures on this topic. We have a student in the hot seat today who will be answering my questions. Let's start with congenital heart diseases. The congenital heart diseases causing early cyanosis, such as tetralogy of Fallot, transposition of the great arteries, tricuspid atresia, and persistent truncus, will all require surgery. But before you do surgery, you can administer a medication to keep patients alive until their surgery. What medication is this?
You give a prostaglandin E1 analog, such as alprostadil. This will keep the ductus arteriosus open to supply blood to the systemic or pulmonary circulation to sustain the infant.
Correct. Let's discuss treatments for the late cyanotic heart defects. One of these defects also can benefit from alprostadil.
You can administer the drug to infants with coarctation of the aorta to increase perfusion to the lower body.
Yes, another late cyanotic lesion can occur in premature infants or patients with rubella. They might have a patent ductus arteriosus. How can you close this?
You can use a prostaglandin inhibitor and NSAIDs such as indomethacin.
That's correct. Let's discuss the treatment of primary hypertension in adults. What lifestyle modification will have the greatest impact on blood pressure?
Weight loss.
Yes, but what if they have a normal BMI?
They should follow the DASH diet.
Correct. What are the first-line medications for primary hypertension?
ACE inhibitors or ARBs, thiazide diuretics, and dihydropyridine calcium channel blockers such as amlodipine.
That's right. For which patients with hypertension might you use an ACE inhibitor first?
Use an ACE inhibitor in patients with acute coronary syndrome or heart failure to also help prevent cardiac remodeling, or in diabetics for renal protection to prevent diabetic nephropathy and proteinuria.
Very good. You will also use ACE inhibitors in patients with renovascular hypertension from renal artery stenosis. For which patients with hypertension might you use a thiazide diuretic first?
Patients with osteoporosis or calcium kidney stones because thiazides increase calcium reabsorption into the bloodstream from the renal tubules.
Correct. For which patients with hypertension might you use dihydropyridine calcium channel blockers?
Nifedipine is safe to use in pregnant patients. You could also use nifedipine in patients with Raynaud syndrome, which will also help relieve vasospasm of arteries.
That's right. Additionally, for hypertensive patients with vasospasmic angina, you could use either a dihydropyridine or non-dihydropyridine calcium channel blocker like verapamil or diltiazem. What are some second-line drugs for hypertension?
Beta blockers, alpha blockers, alpha 2 agonists such as methyldopa and clonidine, and the arterial dilator hydralazine.
Correct. When might you use beta blockers for hypertension?
In a patient with stable angina, you could also use a non-dihydropyridine calcium channel blocker for these patients if they have contraindications to beta blockers.
Good. Hypertension is a common etiology for atrial fibrillation. What medications could you use in the hypertensive patient with AFib?
You could use beta blockers or the non-DHPs verapamil and diltiazem for rate control.
Correct. Note that beta blockers would be preferred over calcium channel blockers if the patient with AFib also had heart failure. What about the use of beta blockers in a hypertensive patient that has a certain neurological condition?
You could use beta blockers like propranolol for a patient with migraines.
Yes, and a beta blocker can be used to treat an endocrine disorder that increases the risk of hypertension because the drug controls some of the symptoms. Which disorder is this?
Beta blockers such as propranolol can be used to treat Graves' disease and thyrotoxicosis. They can reduce the symptoms such as tachycardia, anxiety, and tremor.
Correct. Also, beta blockers can be used to treat a patient with hypertension and essential tremor. When do you use alpha blockers for hypertension?
You could use alpha-1 selective blockers such as terazosin in a hypertensive patient with BPH to relieve the urinary outflow obstruction.
Correct. In which hypertensive patient would you use the beta blocker labetalol, the arterial dilator hydralazine, or the alpha 2 agonist methyldopa?
Like nifedipine, these drugs are all safe in pregnancy.
Good. What are some intravenous options for treating hypertensive emergency?
You can use rapid-acting DHP calcium channel blockers like clevedipine and nicardipine, beta blockers like esmolol or labetalol, also nitroprusside or higher doses of nitroglycerin, and the D1 agonist phenoldiprem.
That's correct. How do you manage the hypertension in disorders of catecholamine excess, like pheochromocytoma or a tyramine-induced hypertensive crisis from patients on MAOIs who ate aged foods?
Use drugs that have both alpha 1 and alpha 2 blocking properties like phenoxybenzamine or phentolamine.
Correct. Let's discuss the treatment of coronary artery disease. What is the best class of drugs for stable angina?
Beta blockers because they reduce the heart rate and contractility and myocardial oxygen demand.
What if the patient can't take a beta blocker because of a contraindication?
You could use a non-DHP calcium channel blocker like verapamil or diltiazem.
Yes. But what if the patient is on a beta blocker, but their angina is still not well controlled?
You could add a dihydropyridine calcium channel blocker, such as amlodipine, to the beta blocker to increase blood flow to the heart and to reduce afterload. Or you could add a long-acting nitrate, such as isosorbide dinitrate, to reduce preload and also increase blood flow to the heart.
Very good. If the patient comes to the hospital and their ECG indicates acute coronary syndrome, such as unstable angina, NSTEMI, or STEMI, what medications would you initially give to stabilize the patient?
The most important initial medication will be antiplatelet therapy, such as aspirin or clopidogrel, or a combination of the two. You also give nitroglycerin to reduce myocardial oxygen demand, increase coronary perfusion, and reduce pain. You can give oxygen if they are in respiratory distress or their saturation is less than 90%. And you could give morphine if they are still in pain to reduce sympathetic tone.
That's correct. You could also give heparin, a beta blocker, ACE inhibitor, and a statin. After these immediate interventions, how do you manage a STEMI?
Patients with a STEMI need revascularization. So PCI is preferred, ideally within 90 minutes of first medical contact. PCI is contraindicated after 120 minutes due to reduced survival benefit and increased complications. Sometimes a GP2B3A inhibitor, such as tirofiban or abciximab, is used at the time of PCI.
Good. What if you can't do PCI within 120 minutes?
You should do thrombolytic therapy with a TPA such as alteplase. Ideally, TPA should be given within 30 minutes of first medical contact and within 12 hours of symptom onset. And you have to make sure the patient has no contraindications to thrombolytic therapy.
Correct. If the patient receives a drug-eluting stent, he will need to be on dual antiplatelet therapy for up to 6 months to prevent thrombosis. What are some indications to perform coronary artery bypass grafting?
Bypass grafting is preferred over PCI if the patient has one of the following indications. One, they have greater than 50% occlusion of the left mainstem coronary artery. Two, they have three vessel disease with greater than 50% stenosis in each vessel. And three, they have greater than 70% stenosis of the LAD with two or three vessel disease, or if they've had unsuccessful PCI.
Very good. How do you manage patients with NSTEMI and unstable angina after you initially stabilize them?
You use a cardiac risk calculator, such as TIMI or GRACE, to stratify patients. Those with an intermediate or high risk of a major adverse cardiac event will undergo coronary catheterization to assess their need for revascularization. Those with low risk will undergo cardiac stress testing to determine the need for coronary catheterization.
That's correct. You don't use thrombolytic therapy for NSTEMI or unstable angina. What medication should all patients with acute coronary syndrome be given long-term to reduce mortality?
Patients should be given dual antiplatelet therapy with aspirin and clopidogrel to reduce plaque formation, an ACE inhibitor and a beta blocker to reduce myocardial oxygen demand and prevent cardiac remodeling, and a statin to reduce plaque formation.
Good. Let's discuss the treatment of dyslipidemia. What is the first-line agent for lowering LDL?
You give a statin, which inhibits HMG-CoA reductase, the rate-limiting step in cholesterol synthesis. This results in upregulation of LDL receptors on hepatocytes.
Correct. What is a serious side effect of a statin?
Myositis, which could lead to rhabdomyolysis and an acute kidney injury.
Yes. And remember, statins are metabolized by the cytochrome P450 system. So P450 inhibitors can increase statin levels and the risk of myositis. Statins are generally not recommended during pregnancy. What medication can you give if the patient has a contraindication to a statin, or if the statin doesn't lower LDL enough?
You can give ezetimibe, which blocks the absorption of cholesterol in the small intestine.
Correct. If these two medications don't lower LDL levels enough, or if the patient has familial hypercholesterolemia, you could add a PCSK9 inhibitor, such as alirocumab, to increase the number of LDL receptors on cells. What is the first-line agent for lowering triglycerides?
A fibrate such as fenofibrate or gemfibrozil.
Yes, lowering high triglycerides is important to prevent pancreatitis, as well as the complications of metabolic syndrome if the patient also has low HDL levels. What are side effects of fibrates?
They can cause cholesterol gallstones and they can worsen the myopathy when combined with statins.
Correct. Fenofibrate is preferred over gemfibrozil in combination with a statin because of its lower potential to cause myopathy. Which medication is most effective at raising HDL levels?
Niacin.
What are side effects of niacin?
Niacin can cause flushing, but this can be relieved with NSAIDs. Niacin can also cause hyperglycemia and hyperuricemia.
That's correct. Hyperglycemia and hyperuricemia are also side effects of thiazide use. Let's discuss some of the medications used for heart failure. First, let's talk about medications for heart failure with reduced ejection fraction. These medications will be used for etiologies including dilated cardiomyopathy. These recommendations are based on the American College of Cardiology and American Heart Association heart failure stages A through D. Patients with stages A and B are asymptomatic. Patients with stage B have some evidence of structural heart disease, risk factors for heart failure, or labs such as elevated BNP, and you will begin treating these patients. What medications will you use to treat them?
ACE inhibitors and beta blockers will be used to improve heart function and prevent cardiac remodeling. Approved beta blockers for heart failure with reduced ejection fraction include bisoprolol, carvedilol, and metoprolol.
Very good. Patients with stages C and D heart failure are symptomatic. What additional classes of drugs will you use to treat them?
You'll add a diuretic, preferably furosemide. You could also use a different RAS inhibitor if the patient has already been on the optimal dose of an ACE inhibitor. This alternative RAS inhibitor is the valsartan sacubitril combination, which has been demonstrated to have greater mortality benefit versus ACE inhibitors.
Correct. Sacubitril is a neprilysin inhibitor, and it results in higher levels of ANP and BMP, which inhibit the RAS system, among other effects. What other two classes of drugs will be added for stages C and D heart failure?
You will add a mineralocorticoid receptor antagonist, such as spironolactone, which can also prevent cardiac remodeling, and an SGLT2 inhibitor, such as empagliflozin, a diabetes drug.
Good. Remember, many of these drugs can cause hyperkalemia, so you must monitor for side effects and the development of arrhythmias. There have been no specific medications shown to reduce mortality in heart failure with preserved ejection fraction, but several medications can reduce hospitalizations. Name some of these medications.
Since the number one cause of heart failure with preserved ejection fraction is hypertension, causing left ventricular hypertrophy, you want to control the patient's blood pressure with drugs such as ACE inhibitors. You also want to control volume overload with diuretics, including spironolactone. SGLT2 inhibitors have also shown benefit.
That's correct. The use of beta blockers in heart failure with preserved ejection fraction is controversial, and some studies have shown that beta blockers worsen patient outcomes. How do you treat hypertrophic obstructive cardiomyopathy?
Beta blockers are the first line medication for HOCM, but you could also use non-dihydropyridine calcium channel blockers if beta blockers are contraindicated. These medications slow the heart rate and also allow more diastolic filling time.
Correct. There is also a new medication called mevacamptin, which treats the underlying cause of HOCM by targeting sarcomere proteins. What if HOCM is refractory to medical therapy?
The preferred surgical option would be septal myectomy to thin the interventricular septum and relieve the outflow obstruction. If the patient is a poor candidate for this procedure, they can undergo alcohol septal ablation.
Very good. Let's discuss the prevention of rheumatic fever and rheumatic heart disease. When children have group A strep pharyngitis, what do you treat them with?
Penicillin. If they have a penicillin allergy, treat them with erythromycin or a cephalosporin such as cephalexin.
Correct. If rheumatic fever does occur, you treat the patient with the same agents. Rheumatic fever has a high rate of recurrence. How do you prevent recurrence? How do you prevent rheumatic fever from developing into rheumatic heart disease? And if a patient develops rheumatic heart disease, how can you prevent it from getting worse?
Okay, if a patient develops rheumatic fever, he must take long-term antibiotic prophylaxis. Every 4 weeks, the patient must get IM penicillin G for 5 years or until the patient turns 21. If the patient develops rheumatic fever with carditis, but no residual heart disease such as valve damage, the patient must be on antibiotics for 10 years or until the patient turns 21. If the patient develops rheumatic fever with carditis and valve damage, The patient must be on antibiotics for 10 years or until the patient turns 40. Some patients requiring valve surgery may need to be on lifelong antibiotics.
Very good. Let's further discuss infective endocarditis. What are some empiric treatment regimens for infective endocarditis?
The most common causes of acute or subacute infectious endocarditis are gram-positive organisms such as staph species, strep viridins, and Galolyticus, and Enterococcus, so drug regimens would have to cover these. Gram-negative organisms include the HASEC group and non-HASEC, such as E. coli and Pseudomonas. Broad screen coverage could be achieved by vancomycin plus gentamicin, or ceftriaxone for native valves with the addition of rifampin for prosthetic valves for biofilm penetration.
That's correct. Let's discuss the treatment of valve disorders. How would you manage aortic stenosis?
If the patient is symptomatic with dyspnea or on exertion, angina, or syncope, or they are asymptomatic but the valve area is less than a centimeter squared, you would replace the valve.
Correct. There is no medical therapy that reduces mortality at this stage. What are the types of valves you can use and advantages and disadvantages of each?
You could use a metal valve or a bioprosthetic valve. A metal valve may be more appropriate in a younger patient because it lasts longer. But the patient would have to be on long-term anticoagulation with warfarin. A bioprosthetic valve may be more appropriate for an older patient. It won't last as long, but you don't have to take warfarin.
Good. How do you manage aortic regurgitation?
Aortic regurgitation will usually be managed surgically. Indications for valve replacement include acute severe aortic regurgitation, chronic aortic regurgitation that is symptomatic, and chronic aortic regurgitation that is asymptomatic but has severe features such as ejection fraction less than 55%, left ventricular end systolic dimension greater than 50 millimeters, which is an indicator of a large regurgitation volume, or they're having heart surgery for another reason.
That's correct. How do you manage mitral valve stenosis?
For mild to moderate mitral valve stenosis, which is usually asymptomatic, you can manage conservatively. For severe mitral stenosis with a valve area less than 1.5 centimeters squared or symptomatic disease, you perform percutaneous balloon valvuloplasty to open up the fibrotic leaflets.
Very good. Additionally, some etiologies of mitral stenosis cause valve calcification, and this may require valve replacement. You also want to be aware of and address the atrial fibrillation and subsequent heart failure that may result from mitral stenosis. Mitral regurgitation can be primary, meaning the valve itself is damaged from prolapse, infections, or an MI, or it can be secondary to left ventricular changes such as dilated cardiomyopathy or ventricular MI that leave the valve incompetent, but the valve itself is not damaged. Regurgitation can also be acute or chronic. How do you manage acute primary mitral regurgitation?
If it's acute primary mitral regurgitation, you repair the valve immediately. Valve repair has lower mortality than valve replacement.
Correct. How do you manage chronic primary mitral regurgitation?
If the patient is asymptomatic, you can use medications that will decrease preload, such as ACE inhibitors, nitrates, or diuretics, and medications that decrease afterload, such as ACE inhibitors, to reduce the regurgitation. Some of these medications, such as beta blockers or ACE inhibitors, can also reduce left ventricular remodeling, which is a complication of mitral regurgitation. If the patient with chronic primary mitral regurgitation is symptomatic with signs and symptoms of left heart failure or atrial fibrillation, or is asymptomatic but has reduced left ventricular ejection fraction, you will perform valve repair.
Very good. How do you treat pericarditis?
The treatment will depend on the etiology of the pericarditis. NSAIDs are the first-line treatment for the most common causes, such as Coxsackie B virus. If NSAIDs are contraindicated, you can give colchicine. You could also combine the two agents. If the pericarditis is caused by uremia, you must perform dialysis.
That's correct. Prednisone can be used if the pericarditis is caused by uremia, connective tissue diseases, or autoimmune diseases such as lupus or rheumatoid arthritis. How do you treat the fibrinous pericarditis or Dressler syndrome following an MI?
You treat with aspirin. Other NSAIDs contraindicated after an MI.
Correct. What if a patient develops constrictive pericarditis, which is pericardial fibrosis from causes such as viral infections or radiation?
You could give NSAIDs, but definitive treatment will be pericardiectomy, where you remove the thickened fibrotic pericardium.
Good. Let's discuss the management of a pericardial effusion and cardiac tamponade. How do you treat a pericardial effusion?
If it's a large pericardial effusion, you would drain it with pericardiocentesis by inserting a needle into the pericardial space and removing the fluid. If this is unsuccessful, you could do a pericardiotomy, where you either make a surgical window or use a balloon to dilate the pericardial space to allow continuous drainage of fluid. Finally, you could do a pericardiectomy, like we mentioned for constrictive pericarditis.
That's correct. How would you treat a large pericardial effusion causing cardiac tamponade?
Do immediate pericardiocentesis to remove pericardial fluid.
Correct. However, in some etiologies of cardiac tamponade, there will be large volumes of blood, and the pericardiocentesis is unlikely to resolve the tamponade. So you will have to perform a surgical pericardiotomy. This can occur if the blood is coming from the aorta in an aortic dissection, the ventricles in a free wall rupture, or the coronary arteries. Thank you for joining us for the first of our 2 lectures on cardiovascular treatments. We hope you learned a lot. Additional notes on this topic will be available at lectureboss.com or by following the link in the video. Take care.